Uh, Good afternoon, students. This is my third lecture of general epidemiology. Till now, we've understood what is general epidemiology, what are the tools of general epidemiology, what are the principles of general epidemiology, the use of general epidemiology, and we started with studies. So, in the beginning, I just gave you a brief introduction about all the studies, and we've seen descriptive study in details. Now, today onwards, we'll be seeing the second part of observational study, that is our analytical studies. So, we're just going forward with that. So, analytical studies, the very first and very important is case control study, and the other one is cohort study. There are some other examples like ecological studies, but most important for you and your exam point of view is case control study and cohort study. So I'll be discussing these two study in this session. So first we start with the case control study. As the name suggests, it has some cases, it has some controls. Okay, the direction of the study is retrospective. Thus, that means the disease has already happened. The disease has already happened. And retrospectively, we are asking some leading questions to our patients so that we can find out the risk factor for those particular diseases. So that's why it is also known as retrospective study too. Okay. So as you can see in this figure, there are some cases, that is people with the diseases that we find out whichever disease we are interested into. Then there are controls which are exactly similar to our cases except for the disease under study. The controls do not have that disease. Then we'll be taking some questionnaires, some interviews, or some other thing, telephonic interviews, by which we'll be coming to know what are the risk factors for these particular diseases. So whoever has been exposed in cases and whoever has not been exposed to that particular risk factor. Whereas in controls also, whoever has exposed and whoever has not exposed to that particular risk factor. And ultimately, over a period of time, how many of exposed people have developed the disease, whereas how many unexposed people have developed the disease. So that is a general idea about this study. Now we'll go step by step. So the steps being selection of cases and controls from the population, matching, measurement of exposure, analysis, and interpretation. So one by one now, selection of the cases. How do we select cases from the population? So very first is prior definition. This we've already discussed in previous session, that you have to have a definition, your own definition or the operational definition for that particular research purpose, which will define your disease. That means the eligibility criteria, whom to call as cases. For example, if you're studying a person with oral cancer, okay, if you want to do study on people who have oral cancer, but you want to concentrate your effort only on the stage 1 and stage 2, then your operating definition will be only including the people who are having oral cancer stage 1 and stage 2. You cannot have patients who have stage 3 or stage 4, okay, or who have been cured of that particular cancer. So that is your operating definition. Even if the stage 3, stage 4 people, they come under cancer only, still you cannot include those people into your study. So this is your operational definition, which is a different from your bookish definition. So the diagnostic criteria of the disease and stage of the disease should be explained into that particular definition. As I've given you clue that if you're including only class 1 cancer patient or class 2 cancer patient into your study, then you have to have specific diagnostic criteria for them, in which diagnostic criteria, what will be the outcome after that diagnosis, which will be considered under your study, which will be considered as class 1 and class 2, and which will be considered after in class 3 and class 4. Okay, then that ultimately will lead to your eligibility criteria. That means inclusion and exclusion criteria. That means whom to include and whom not to include into your study. It eliminates the possibility that long-term survivors of the disease were exposed to investigated risk factor after a onset of disease. That means there won't be, this we generally do to reduce the amount of bias of our study. Okay, so normal sources of cases that we generally can find out is hospitals. So if you're searching for any people who are having cancer, you cannot just go door to door and ask everybody. Hospitals is the best source. Then the general population, if you cannot find your cases or your sample size into hospital, you have to go to general population, but it is more tedious and more difficult to get. Then the second step is selection of controls. Once you find out the cases, you have to have controls. So what is the difference between your controls and your cases? Cases are generally exactly similar to your controls. Only thing is that the disease is not present. The disease is not present because we want to keep them away. We want to study what are the risk factors that are there into the cases which are not there into the controls, and that's why the cases are having disease. So that is the basic hypothesis behind this study. That's why we take people here who do not have that particular disease. So there are various sources of control again, like hospital controls. For example, if you're taking for cancers, if you're taking for cancer patient from one hospital into same hospital, you can take patients which are having other ailments but not cancer, right? So that is the easiest way. Then the relatives, since both relatives and the patient, they stay in the same neighborhood generally, they have same habits, lifestyles, that's why we can have relatives as controls. Then neighborhood controls, that means if you're studying a disease which is common in that particular area, then neighborhood people who do not have that disease can act as a control. And if you cannot find controls anywhere from this, then general population is only answer. You have to find out your controls from the general population. Now the number of controls, they say that minimum there has to be one case is to one control. So for every one case you have to have one control. So either you can have a pairs of case and control into your study, or you can have groups of case and control into your study. So minimum 1:1 ratio should be maintained. Maximum 1:4 ratio is allowed. Okay, when you have one case, you can have four controls for your case. Okay, so maximum 1:4, minimum 1:1. Okay, then we have next step, that is matching. Now, what do you mean by matching? What am I saying here is, again and again, I'm saying that cases should be exactly similar to your controls. Cases should be exactly similar to your controls. That means what? That means what? For the age, for the gender, for the socioeconomic status, or for education, you can say lifestyle habits or the occupation, anything that should be similar or matching into cases and controls. And only one thing should differ between cases and control, that is the disease status. So the cases should have diseases, whereas the control should not have any kind of same disease. At least same disease should not be there into that particular control that you are taking into consideration, so that nobody can say that this disease, when we are comparing between cases and control, there should not be a confounding factor. Now what do you mean by confounding factor? Confounding factor means that factor which is related to both your disease as well as your risk factor, and it can influence both your risk factor as well as your disease. So it is the outsider influencer which can enhance the relationship or decrease the relationship between the risk factor and the disease. So such kind of factors are present which may modify the relationship between your disease and the risk factor. You may not have right results for your study. So matching is done to remove or to at least minimize this confounding factor. 100% confounding factor cannot be removed, or 100% errors cannot be removed, but matching is one of the way with which we can minimize having errors into our study, and so that your study results will be more and more reliable. So your cases and control, again and again I'm saying this, your cases and control should be such that they should be similar in each and every aspect, like age, like gender, occupation, education, ethnicity, lifestyles, the geographical area, everything should be similar except for one thing, that is the disease under study. The cases will have disease and the controls won't have disease. That is the meaning of matching. Okay. Then there are types of matching, like I've already told you, that group or frequency matching. That means if you have so many groups of cases, then you have to have that many groups of control, or you can have one-to-one pair matching, that is one case and one control. Like that also you can admit your participants into your study. Now, the next step is measurement of exposure and other factors, right? So, to measure what are the various factors, exposure factors, which we want to, or risk factors, what we do is, first is interview. Face-to-face interview, you can ask some leading question. For example, if we're having a study, like we were taking an example of oral cancer. So in this interview, you can inquire about the habit that they are having, whether they are having any tobacco chewing habit or alcohol habit, or whether they are exposed to sun so much, or they're eating more spicy food or areca nut, and what is the frequency, such kind of a leading questions, where they keep for how many time do they chew, for how many times a day they have that habit. Like that questions we can ask into the interview. Same type of questions with multiple choice we can put into questionnaire when the population is literate. Then again, second, another thing what we can do is we can study the past record of the cases. In other cases, like for example, uh, if we have some study on orthodontic cases, already treated orthodontic cases. So if you want to find out the previous malocclusion and then you have to have some conclusion, then you can study the past record of those cases or those people. Then clinical or lab examination. For example, some things are based on clinical or lab examination, like CBC, that is the how much is the normal uh, uh, normal WBC, RBC counts. Then second thing, when you're doing any study on diabetic patient, then how much is their, how much was their daily sugar, or any, what do you say, cholesterol level, if you're doing any study on cardiovascular diseases. So these are investigations we can have from the lab. Now, once you have all the data collected with the help of these interview, questionnaire, lab investigations, or past records, once you have all this information, you have to put it into a table that is called as 2 by 2 contingency table. That is the most important. So you can see this. This is called as 2 by 2 contingency tables, where the amount, the number of cases that we have studied as cases and controls for lung cancer I have put, and smoking and non-smoking. So for the second column, you can see there are cases, and smoking means those are the exposed group, and non-smoker, those are the people who are not exposed to smoking habit. For controls also, you can see there are people who are exposed to smoking and who are not exposed to smoking, that is non-smokers, and we have labeled them A, B, C, D. Okay, so exposure rate in cases can be calculated by A divided by A plus C. That means the entire cases, out of which how many cases have exposed. Then in control, same, B divided by B plus D. So out of controls, all the controls, that is B plus D, how many patients were exposed. So we will be getting the exposure rate. Then once we get that race, relative risk or the odds ratio is the statistical analysis, or the statistical analysis generally we do in analytical study, be it a case control study or a cohort study. So what do you mean by relative risk? So we find out how much risky it is to indulge into that particular habit, so that we'll get that particular disease. So the formula being incidence among exposed divided by incidence among non-exposed, that we have already calculated, that is A divided by A plus C divided by B divided by B plus D. Then the odds ratio, or the cross product ratio, which is mostly used in case control study but very rarely used in cohort study. It measures the strength of association between risk factor and outcome. So how the both things are connected. How much is the strength? Means how much would you indulge into that habit to produce that particular disease, and how much will be the disease produced. It is closely related to relative risk. The cross product ratio is, odds ratio is AD by BC. AD by BC. That is the formula. Now in this formula, I put some values from the previous table. You can see that the value came as 8.1. Now what do you mean by this value 8.1? This value says that whoever is exposed, is exposed for that particular risk factor, they have 8.1 time more chances of developing disease into future as compared to the people who are not smoking. In this case, smoking is the exposure. So whoever exposed to that particular risk factor, they have more 8.1% more chances of developing that disease as compared to who were not exposed. So thus it shows the strength of association between risk factor and the outcome. So whenever the odds ratio come as 1, there is no correlation between, no association between your uh, risk factor and outcome. Whereas if your odds ratio comes as positive, that is more than 1, then there is a positive correlation between your uh, risk factor and the outcome. That means if one is increasing, another will increase. That means if the risk factor are increasing, the outcome or the amount of disease will increase. Whereas if your odds ratio comes as negative, at that point there is a negative correlation between the two. That, what does that mean? That means if the risk factor increases, the disease will decrease. For example, in case of studies where nutritional diseases, okay, so if someone has scurvy and if you advise them to have citrus food, or if you prescribe them vitamin C tablets every day, what will happen? This amount of scurvy will decrease down. So there you will have odds ratio which is in negative. That means whoever had citrus food or whoever had vitamin C, they will develop less amount of scurvy. Okay, so there is a negative correlation between this. So that is the meaning and the interpretation of odds ratio. Now there are various types of biases. Biases means there are errors that occur into your study. You try and minimize them many a times, but at times you cannot, because of the you try and minimize. You cannot completely eliminate these errors, but you always try and minimize so that your study will be more reliable. So first is selection bias. That is, there are two types, that is prevalence or incidence bias and admission rate or Parkinsonian bias. So prevalence or incidence bias means uh, how do you select your patient? If the the investigator, his own agenda, and if he wants to do that study in his own way, then there will be some bias that has been come into occurrence. Or second thing, at the time of admission, if there are specific things like if you do your admissions during a time of epidemic, so the different representation will be there as compared to normally when you admit your patients. Then second is admission rate or Parkinsonian bias. This is a hospital related bias. So depending upon that hospital, the rates of admission will be different. Then second is confounding factor that we've already learned about. Then the information bias, that is memory or recall bias. What do you mean by this? See, in many of the modern diseases, they do not appear for a small period of time. They go on for decades. For example, diabetes. Okay. So in a diabetes patient who already has 20 years of diabetes, if you ask some questions, they may not recall whatever happened to them before 20 years or during these 20 years or just for 1 year. Okay, so that leads to memory bias or recall bias, even if there are findings, but the patient will not be able to elaborate. Then second is telescopic bias. What do you mean by this? The telescopic bias means what happens, the as cases, they are more prone to have these kind of interviews at the hospital level or at other centers, so they remember the details more clearly as compared to normal patient and compared to controls, because they do not have habit of keeping track of all these things. So cases will give you more detailed history as compared to controls. Even if controls have that kind of a history, they do not remember or they cannot communicate with you. So that is a telescopic bias. Then the interviewer's bias or the exposure suspicion bias, where interviewer, when they know these are cases and these are your controls, they take in-depth interview of cases, so that they can get some positive finding out of them, and they do not entertain controls more, or they do not take in-depth interview of controls, as they know that they won't be getting much information from these. So that is the interviewer's bias or the exposure suspicion bias. Now, what are the advantages of case control study? First is it is the easiest study to do. Then rapid and inexpensive. It is very rapid. Only once you have to go to the patient, once only you have to gather the data. And it is quite inexpensive as compared to your randomized control trial or cohort studies. Requires few subjects. For rare diseases and diseases about which less is known, is generally used as a case control study. No risk to the patient, since we are not intervening with their day-to-day habit, we are not giving them any drug, we are not asking them to leave something into their life, we are not stopping any medication or any kind of a strategy we are not giving. So there is no risk to the subject. We're just asking some questions, on the basis of that we are having some conclusion. Allows the study of several etiological factors at one point of a time. So many factors can be studied only in one single study. No attrition problem. What do you mean by attrition? Here is not dental attrition. Attrition means loss to follow. So we do not have here follow. We are going to the patient only once. We are gathering whatever information we want in just one go. So there is no problem of attrition. Ethical problems are minimal, since we are not interfering with their life. We are not giving them anything. So there is no ethical problem. Now, even if this study is good, there are many of the advantages. There are some limitations also. So very first is problem of bias. That means many kind of a bias can come into the study. Cannot measure incidence, measures only relative risk. So this study is good to measure the prevalence of the study. That means all the cases which are already there, whatever new cases they're coming into the population, this study cannot measure that. Measures only relative risk, no other factor, does not distinguish between cause and associated factor. So it only says there is a correlation between risk factor and the study. It cannot embark that this is the only risk factor which is responsible for this study. To produce that proof, we need to do cohort study or the experimental study. So it just says there is some association between this risk factor and this disease. But 100% with the help of case control study, we cannot make a statement that definitely there has to be some relationship. For that, we need to do cohort study and randomized control trial. Obviously, for cohort study and randomized control trial to do, we need to get this study done so that we have at least some association between the risk factor and the disease. Not suited for evaluation of therapy or prophylaxis of the disease. So with this, I would like to end my session on case control study. In next session, we'll be learning about cohort studies. Thank you.